Alcohol withdrawal syndrome. The pathophysiology. So at low concentrations of ethanol, there are euphoria-like effects due to glutamate binding to NMDA receptors. At high concentrations, there's acute intoxication due to potentiation of GABA effects. Sudden halting of chronic alcohol consumption unmasks these changes with the glutamate-mediated CNS excitation. There is an upregulation of NMDA receptors and GABA A receptors because the GABA A inhibitors are reduced. This leads to autonomic overactivity and neuropsychiatric complications such as delirium and seizures. So as you can see in this neurochemistry figure, is first you see the equilibrium of glutamate and GABA. Then you see when you have alcohol, when you ingest alcohol, your GABA reduces, and then there's chronic use where your glutamate becomes upregulated, and there's a withdrawal state once you stop taking alcohol, where your GABA is reduced but your glutamate is upregulated. So signs and symptoms: mild to moderate tremors, irritability, anxiety, agitation, delirium, hallucinations, shakiness, and loss of appetite. In terms of treatments for alcohol withdrawal syndrome, so for treatments in an ambulatory setting, the optimal treatments are benzodiazepines such as chlordiazepine oxide, which is a long-acting benzodiazepine, or anticonvulsants, such as gabapentin. So benzodiazepines treat the psychomotor agitation as well as decreasing neuronal activity in order to prevent the progression of mild symptoms to severe symptoms. Gabapentin has been shown to be a safe alternative due to it having lesser side effects and unwanted side effects. So it relieves the other symptoms of alcohol withdrawal syndrome outside of the main ones such as delirium and seizures. It works in alcohol withdrawal syndrome by inhibiting GABA receptor mediated inhibitory postsynaptic currents in the central nucleus of the amygdala and decrease dependence induced alcohol drinking. So here, this is a flow chart of how to approach a patient with severe alcohol withdrawal. So you want to apply the monitors, be able to have access to IV, make sure you check their blood glucose, and consider blood work and CT head to evaluate for any other causes of altered mental status. You would start off with a loading dose of either diazepam 10 milligrams IV or lorazepam 2 milligrams IV, which is usually used in hepatic patients. So then you would reassess in 5 to 10 minutes, and if there is improvement, just monitor every 15 to 30 minutes and just to see if you need more benzodiazepines. And if the symptoms worse, they increase the dose. But if you notice there's no improvement, increase the dose right away, check vital signs, and make sure and sedation, and see if you need to incorporate larger doses. After that, if there's improvement, then just keep monitoring. If there's no improvement, consider adding phenobarbital, and if there's no improvement even after that, consider intubation and other adjunct therapies, such as using propofol or dexmedetomidine. In terms of prevention and prophylaxis, you want to initiate long-acting benzodiazepines in high-risk patients to reduce the risk of severe symptoms from occurring. Usually there isn't much prophylaxis you can do with alcohol withdrawal syndrome, just because you don't want to go cold turkey if you have chronic alcohol consumption, but the best way is through these prescription long-acting benzodiazepines. So patients considered high risk are history of withdrawal seizures, history of delirium tremens, or prolonged heavy alcohol consumption. Typically, alcohol consumption is tapered down while taking benzodiazepines to better improve the quality of prophylaxis. Monitoring. So patients are monitored through the CIWA-AR every 4 to 8 hours until a score is less than 8 to 10 points. The CIWA-AR scale is a 10-item assessment utilized to quantify symptoms in order to measure severity of alcohol withdrawal syndrome. As you can see on the right, this is an example of that scale. And based on the score you get is how we determine what severity of alcohol withdrawal syndrome you have.